Hey there, welcome again. Welcome back to The Digital Lever by Mezzanine. Very excited about today's podcast in the second episode of our podcast here with Peter Breitenbach, who is the head of strategy and product at Mezzanine, and very excited to talk about immunization and interoperability, which is all about how digital toolkits are transforming the African healthcare sector. And obviously this is a very, very sort of important, forthright topic right now, given the multitude of all sorts of emergencies and pandemics that we all seem to be facing around the world at the moment. But we're going to kind of zoom in a little bit today and discuss with Peter what Mezzanine and some of the other stakeholders, some of the other partners are doing at the moment to address these sorts of problems. So thanks for joining us on the Digital Lever today, Peter.
Yeah, thank you. It's a pleasure to be here. For those of you who don't know, I am the oldest person that works at Mezzanine, and I've done just about every job you can imagine within the organization. So like most people within Mezzanine, sometimes we are MD's PA, and other times we get to do our proper jobs as well, but it's a fantastic place to work, and I've been part of the journey since 2010 when it was set up, with literally, 2 men and a dog and so forth. So we've come a long way to get it to the point where they're now, I think, just in excess of 80 people in 3 different parts of Africa. So yeah, good to be here. Thank you.
Lovely. And what a journey it indeed has been over sort of 10, 11 years, growing to, I'd say, become quite a substantial force on the continent in a variety of different sectors. And I suppose today we're going to be speaking a little bit about the progress that Mezzanine has had specifically in the healthcare and the sort of the stock visibility management of vaccines and other pharmaceutical products in a time when clearly this is of a great need. So are you able to kind of maybe set the scene for us? Tell us a little bit about maybe the status quo, if you will, on across various different African countries, how these sorts of programs are managed and some of the challenges that they're facing at the moment.
Yeah, sure. So a couple of ways to answer that. I mean, where we are right now is that of the 55 member states in the African Union, about 46 of those have signed up or are signatories to the Gavi-mediated or Gavi-run COVAX AMC facility, which is a pooled procurement modality. And that effectively acts to purchase vaccines and potentially other services from different global vaccine providers and so forth, and then provide them to these countries. So out of those 46 signatories, I think as of Wednesday, 12 have actually started receiving batches of vaccines, and that excludes South Africa, who's not a signatory to the AMC component of COVAX. So vaccines are starting to happen and being now rolled out in a number of these countries. A couple are still busy going through the regulatory approval process and sorting out, amongst other things, the various systems and the processes to support the provision of these vaccines. And that's exactly, where we believe that our capabilities and so forth and our expertise, which has been developed over 12 years of doing this, in very disenfranchised and difficult resource-constrained environments, across Africa, which is really our main focus, and our raison d'etre is about leveraging that ubiquity of digital that Africa is so famed for, and leveraging that to enable enterprises to be able to access, some people call it the bottom of the pyramid. We don't see it as the bottom of the pyramid. We see it as the top of the pyramid. It's a bit of it's not a great way of describing it, the bottom of the pyramid, but it enables enterprises to use mobility to be able to connect and engage and transact, with citizens and beneficiaries, and vice versa. So now you're enabling someone that doesn't ordinarily have the ability to engage and transact beyond their sort of hyperlocal space and the hyperlocal markets. Now you can enable them through digital to engage with, global credit providers and insurance providers and so forth. And and ability to access certain services. So,
Yeah.
so that's where we are with respect to vaccine rollout at the moment. And the expectation is that I think by the end of this year, somewhere between maybe 20 and 27% of AU member states' adult vaccine needs will have been provided for through the COVAX AMC facility. So that remains to be seen, though, exactly. Just taking a step back from that, though, and just looking at, one of the questions that we often get asked is, what has changed between then and now, with respect to what we do and what our competitors do and so forth? And I think the point I wanted to make around that is that, and there's a great French way, a French saying, plus ça change, plus le même change, which basically means as much as things change, they still stay the same. And with respect to healthcare in Africa, I think that's a truism, is that nothing has changed and yet everything has changed. And the nothing but that hasn't changed for me is that people still battle to access essential services. The quality of the services is often poor and substandard. And the ability of systems to withstand these shocks and so forth, the sort of inherent resilience within these systems just does not exist. And there's a very interesting report done by the WHO, I think a year or so ago, that attests to this, effectively saying that countries are only half ready to be able to provide, from a performance point of view, to provide these kinds of services and so forth. So that bit hasn't changed. There's a lot of work to be done. That's why Mezzanine exists. That's what we do, and that's what we're really successful at. What has changed with respect to where we are now, and potentially you could say that the door into the barriers to entry with respect to consuming digital services has changed. I mean, I would agree with that, and I'd say there are a number of different converging forces at play there. The first is that, the pandemic itself has just an amount of money and resources that are coming in, and not just into Africa, but around the world. It's just massive. I mean, the World Bank, I think, has allocated something like 160 billion. And this goes back to last year. So it's just huge amounts of money. The EU, I think, has put in 750 billion euros into their recovery plan. So I don't think we've ever seen the likes of this wave of investment and support that's come into the markets. But with that comes scrutiny. And part of that scrutiny is to understand what is the ability here and how do I manage and mediate or mitigate my risk as an investor, even if it's grant financing and so forth. So people are now wanting to understand, well, what is your capability from an information management point of view and so forth. And so I think finally it's kind of elevated the conversation, but this bit hasn't gone away. There's still these massive problems and challenges.
Yeah.
So the mistake that people often make, in my view here, is that they'll go and buy the world's best packet of Elastoplast or Band-Aids, and they'll just put them all over the problem. But you haven't solved that issue underneath there. And so whatever approach is taken here, and this is certainly our hope, and we've been evangelists and communicating this for years, this is a long-term thing still. You can go in with a digital solution and you can solve the issue to hand now, which is about the way we said, linking supply and demand intelligently, so the right person gets the right vaccine at the right place at the right time, in the right condition. But there is a longer-term play at stake here. And just to give you a sense of the impact of the pandemic in Africa. So globally, I think somewhere around 4% decline in GDP. And then I think it's fair to say at least 60, if not 70% of member states have similarly experienced a decline in their GDP. Some have gone into outright recession. The effect, that's
devastating.
That's terrible. It's absolutely terrible. And you can understand why people are so desperate to have the vaccine, and it becomes, of course, we want to get over the immediate impact of morbidity and mortality and the effect that it has on people, particularly those with comorbidities and so forth. But from an economic point of view, that in itself is a huge driver for the need to get your population vaccinated as quickly as possible. The point is that Africa cannot, like many, or many of its member states, cannot withstand another enforced lockdown and so forth. There is just no way that you can do that. South Africa lost, I think it was Stats SA last year said 600,000 jobs. It could even be more. It's been profound, the effects of it. And so the sooner countries are able to vaccinate the adult population, the better. The problem is that you've got these existing challenges, you've got a set of new challenges because you now need to vaccinate adults, not children, adults, using, in most cases, the rails that were used from an infrastructure, systems, policies, processes point of view that was designed for children, or EPI vaccines. And now, in addition to that, it's not like we have an oversupply of vaccine. We have an undersupply, potentially going on for 1, maybe even 2 years. And how do you rationally allocate this very scarce commodity, dare I call it that, against this overwhelming need and demand by people on the ground to be able to access this?
And what you say about the fact that this is no longer a healthcare problem but an economic problem is so true, of course. And in a place like Africa, where it's obviously an emerging, developing continent with its own kind of bustling economies, it just really shows how brittle things really can be when it's shaken to the core with something like this, and it becomes an economic problem. But at the same time, when you're talking about those challenges that are ahead and behind, I suppose a lot of it has to do with the infrastructures of managing data and managing information that allow these sorts of rollouts, these sorts of large government-led programs to work, or at least to put them in place in the first place. And so, just at a high level, maybe, where is Africa at the moment when it comes to the digitization of primary data, not only collecting that data, but then meaningfully doing something with it, analyzing it and putting it into the right place in order for there to be an effect on the end beneficiaries, the patients in this case?
Yeah, if there was one word to describe what Mezzanine does, it's that word, data. It's about getting a torch, basically, and being able to shine it for your client to be able to generate and consume that data in order to inform decision making and so forth. And right now, I think it's fair to say that in almost every healthcare system, primary care level data is collected on paper. There are very few systems that are out there, digital systems, that have been deployed and have remained successful and or have scaled. Very few.
And when you say paper, you really do literally mean paper?
100%. Yeah. When we first set the first version of mVacciNation, which we took to Mozambique and then to Tanzania and then to Nigeria, where we captured, I think, 1.3 million vaccinations. We'd go there, you'd sit outside these facilities, and as you would expect, there are just rows and rows of moms and their kids and whatever. I mean, literally like hundreds. And you walk inside and they have different stations, and one station is where they weigh the baby and then they record that in a register, literally like this size. And then the next patient baby gets put in the sack and weighed, and then they go to someone else and whatever. And when they get to having the vaccination actually physically done, there's a book. I kid you not, you would probably need a Land Rover to carry this thing. It's so massive. I mean, it was known as the vaccine register, I think it was, for obvious reasons. But it literally was going back years. But that was the thing, that single book.
That was it.
That was it. That was the repository of all the data. And it was respected, and they looked after it, and they paid huge attention and care to this thing because that was their single record.
Right.
But what they then used to do was to copy that, what they'd captured every day, on another piece of paper. They would give that to someone, they'd go to the next facility and they would collect that piece of paper and the next piece of paper. Then that would go up to the sub-district person, a data capture. He would amass all of it and create one piece of paper. Then we go to the district, and they would collate that. And then finally, someone would enter it into an Excel spreadsheet, which then got put into a USB, got put into a car, and days later or weeks later would land up in the capital and so forth, where people would eventually look at the data. So people have long used these legacy paper-based systems, and I mean, as I've just outlined now, it's complex, it's expensive, it's prone to errors. The veracity of the data is poor, and consequently, how can you expect people to be proactive about decision making when they don't even trust the data to start with? And it's just difficult, unless you've thought through the whole process. How do you actually is this data clean? What format do I need it in order to make intelligent decisions and so forth? So that's exactly what we do and so forth. So being able to now digitize key components within the value chain. If you take vaccines, those core components relate to the stock and around the beneficiaries and so forth. And how do you manage them individually and then together to extract that data that enables you now to connect this piece of stock to that specific individual? And that's exactly what we've done now with mVacciNation.
So that's kind of what you're talking about there, is sort of the I suppose part or maybe all of the definition of interoperability, right? Being able to kind of place in different types of inputs, whether it's different systems or different types of inputs, and being able to still have a predictable result because the system or the operations of the system work, at its core, at its function. And so maybe you can kind of shed a little bit of light on that aspect of this digital toolkit of mVacciNation, how not only how it works, but how it sort of really helps to solve this issue that we've been talking about, where you're taking things that were literally done on paper and now being able to just transport it light years ahead to the point where it offers all of these benefits for governments, for stakeholders, for beneficiaries, almost immediately, almost overnight.
Yeah. So at the outset, I think I should have mentioned that I'm a clinician or a medical doctor by trade, and not a technologist. So the word interoperable...
I'll call you Dr. Peter from now on.
Oh, please don't. The word interoperable, when I first joined this environment 10 years ago, doesn't scare me so much anymore, but I wasn't quite sure what it meant. And at its heart, it's just about, is your system capable of engaging and sharing information with other systems? It's as basic as that, and vice versa. And, the thing is, we've been doing this for years. In fact, if you can't do it, you're not in the game. And you can't call yourself, a company that provides these digital solutions, because it is a requirement. And not just in healthcare and so forth, which is a complex environment, but also in agriculture and education and so forth. And if you look, for instance, at what we've done in South Africa in supporting the National Department of Health with their electronic vaccine management system, I think there's something in the region of 20 different databases and so forth that we've integrated with and are interoperable with. And if we get to a point later on of actually explaining a bit more of the detail of the flow and how the system works and so forth, I think you'll understand then why it's a necessity to be able to do that. It's not a scary conversation for us. You just have to do it, period. So we're quite comfortable with it. We've got a lot of very learned individuals within our firm that have been doing this for a long time. So they're quite happy and so forth. So very much part and parcel of what we do.
Okay. So maybe then just give us a bit more detail then at this level when it comes to the product itself, the toolkit. And your Mezzanine is sort of specifically calling it a toolkit because it's a sort of an amalgamation of a couple different layers on the open source architecture, right? So how does all that work? What are the different constituents and how do they work together to provide this solution?
Yeah, so the reason why we call it a toolkit is because there are too many engineers in the business and there are not enough clinicians. I'm just teasing, but it's a nice description, isn't it? But it is a kit. It's like a box that's got these different layers and capabilities and whatever that came from purpose design solutions, and where we've taken almost the best components from other solutions that we've had in our armory or our portfolio for many years, even things from outside healthcare. So it is very much a toolkit. And it does, at its heart, as I said earlier, it's about the intelligent balancing of the supply side to the demand side. And the first point, let me start with the beneficiaries. In other words, another word for a patient. I just don't like calling them patients because they're not sick. They just need a vaccine.
Exactly.
So that bit is you need to understand, identify who these beneficiaries are, and then you need to be able to attest or validate or verify who they are. Not everyone is a doctor. It's interesting. A lot of people have tried to jimmy the system in this country, and they'll continue to do it because that's what humans do. But once we've been able to validate that individual.
And when you say validate, that means sort of tying them to some sort of digital signature and identity.
Well, yes. Well, right. Certainly in this case, if you claim that you are a medical professional or a paramedical professional, your name and number, as it were, exists on some database, professional database. And so this is my earlier point about interoperability. You know, if you then link your system to that system, you're then able, or a third-party system, you're then able to effectively ping in real time and validate, you know, who that individual is, who they say they are. I mean, if you, for instance, go to Pick and Pay and you want to open a bank account with time, I think it's time. That takes, I think, 3 or 4 minutes before the machine will issue a card. All that validation is going on in the background in real time with various departments and whatever it is, maybe tax authorities and all the rest, just to attest to who you are and so forth. So the important point is once you've done that, so you've now moved to almost the second point, you then need to align it to where that individual fits within a country's prioritization plan in terms of the vaccine rollout. Recall that no country, of course, unless you live with Justin Trudeau, then you're extremely lucky. But let's not get into that discussion, okay? I'll get really upset, and I don't want to do that. But you need to understand where individuals now fit in terms of that prioritization. So healthcare workers in this country and most countries around the world are in the first cohort, then followed by potentially essential workers, then followed by people with comorbidities, blah, 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 blah. Okay. Then the rest of us, sadly. And you'd think, despite my age and so forth, that, you know, I'd be in cohort 2, but nothing could be further from the truth. So once you've done that, then you need to link that individual to a very specific point where vaccines will be made available or are available. So you have the identity, it's been validated, and you have a service point. Great, let's put that aside for a sec. Now, the other part of the toolbox is the stock visibility and the stock management component. So that sits at the level of every single vaccine service point or facility where vaccines will be provided. And that provides you with real-time visibility over the levels of the stock that are required to provide you with the vaccine. So it's not just the vaccine. The
inventory, in other words, right?
Exactly, yeah. And here's an interesting thing. There was a guy from DHL, I think he was the CEO for Africa, the MD for Africa, at a talk or presentation recently, who said that for every pallet of vaccines, there are 50 pallets of commodities that are required. Can you believe that? That's incredible.
Wow.
No wonder, you know, organizations like DHL and others are required to do this because it's just so complex.
And when you say commodities, those are the additional sort of supplies that need to be kind of administered alongside the actual dosage as
Needles,
well, right?
swabs,
okay.
PPE, you know, there may be other things as well, and so forth. But so once you've got a view of the levels of the stock and so forth, and here comes the really cool part, and you link that now to those validated beneficiaries, and you've aggregated demand to that specific point, you now know how many people want vaccines at this specific point and how much is available. And you can say,
it's no longer guesswork.
Okay, exactly, it's gone. And now if you have a control tower sort of view where all this data is aggregated and you have an advisory capability, you know, that's suitably enabled to make decisions, you know, quickly and so forth, rather than defaulting through, you know, traditional decision-making mechanisms which take too long, you can now replenish that stock down that specific arm to those specific facilities and so forth. So once you've got that right, and crucially, you also need to know what vaccines are coming into the country. So when is the next batch coming? Because clearly, if you don't have stock coming in, then there's no point in now lining up people to go and get, you know, immunized at vaccine service points. So you need that information. And then you need to also understand the throughput. How many people can be vaccinated per facility per day? And that depends on a number of things, not least the number of people that can vaccinate or register to provide vaccinations, but a number of different things. And once you've rolled all of that together, then the ministry, as effectively the owner of the solution, can now press the big green button and start effectively sending people to get vaccinated. And the way that that's achieved is we've linked that into our vouchering capability. So voucher is nothing...
Which is the other component in the toolkit.
Yeah. So a voucher is nothing more complex than an alphanumeric code that a 5-year-old can read. And it sits in an SMS, and that is the mechanism of the currency of exchange. That is the value that we're sending to somebody who only owns a feature phone. You don't need to go and buy expensive kit, have access to data and all the rest of it. We're using, basic communication channels to affect this, which is super important. And we also do that on a network agnostic basis. So we're not just limited because we're a Vodacom company to providing these services to only where Vodacom has a GSM license. We do it across the board, using aggregators and so forth, which is very important. And once that patient receives the voucher, they then will, which tells you, the facility you have to go to, the date you have to go to, and potentially even the time and so forth. That depends on a number of things. Then they will get there and they will be validated into the system in real time. They'll receive the vaccine. And if it's, say, the first out of 2 doses, then the moment that dose has been given to you, it is then captured into the system. So it updates your digital record. And the system is automated to then send you a new voucher for 6 weeks hence or 2 months hence.
The next one.
Exactly, yeah. So it's a form of reminder and so forth. So conceivably, we've got the capability to build additional intelligence into it and demand messaging, compliance management, and so forth into it as well. And then upon completion of that particular vaccine regimen, whether it's one like a J&J or 2 like a AstraZeneca and others, or most others, the system can generate an electronic PIN, which is just a way of saying you've had the vaccines and well done. But we won't, as a company, print those out and in effect give them to people in their hands and so forth. But it is available if people require it. So that's basically how it works.
So amazing, and it makes sense as almost like a closed loop system that has each of those constituent parts working together because of the magic glue of interoperability, right? So now when it comes to kind of engaging other parties, other stakeholders, not just the healthcare facility or the regional service point and the beneficiary, the patient, but when it comes to the heads of ministries and potentially other third parties that are perhaps offering a service on top of this or whatever the case may be, how do you see that ecosystem forming? How do you see those sorts of stakeholders getting involved, leveraging the toolkit, but also being able to kind of add to the value added services?
Yeah,
or create them.
So I think an important point is that we've been doing this for a while. We understand, and I come from that background. And healthcare is what's known as a complex adaptive system. It requires so many different actors to do so many different things, but all at the same time. It's like an orchestra. You've got, the wind instruments, and you've got the timpani, and you've got this, and you've got that. You have all of them together, and if you've got a good enough conductor, then that orchestra really sings, for want of a better description. That's exactly what healthcare is. And if you lack any of those particular instruments, you can hear, it just doesn't work, and it doesn't make oral sense to you and whatever. And healthcare is no different from that. So what we do is just one component of that. There are so many other actors that are required to make this whole thing coherent. You need supply chain experts, for instance, that work on sort of the upstream, how the vaccines get into the country, how they're managed, how they move through the supply chain, and so forth.
Yes.
You need analytics experts that do this for a living, and many, many others. And we're fortunate in that we've built, a great team around us to be able to provide those kinds of insights. But importantly, just coming back to the way the system is designed itself, you need to be able to be interoperable with other systems. So if, for instance, a ministry has an existing relationship with a cold chain provider, so you get these cool little things, look like a USB, you can put it in a vaccine tray and it'll just collect information through its Bluetooth heart, basically. Or it'll collect information and around the temperature and the humidity and so forth, and then if you get near it with a suitable device, it just uploads all that data through Bluetooth. So, and that gives you visibility over how that vaccine has been managed from a cold chain perspective, ideally from the point of manufacture or at the gate, all the way through to the facility when you're about to give it to another person. And so we will happily, at the ministry's requirements, we'll happily integrate our system with those third-party systems and so forth. And there'll be others. I mean, we won't get involved, and we can't get involved because of the medical legal liability element in, for instance, the pharmacovigilance component, the tracking of symptoms and what you do about side effects and those kinds of things. That's a very rarefied and very specialized environment that obviously we can't get involved in. But if there's a requirement for us to shift that data to that third party, again, at the ministry's discretion, then we're very happy to support that.
The capabilities there. Yeah.
And that's the important thing. I mean, and that's what makes what we do. And then there are other companies that do similar things. You need that, I don't think ostensibility is the right word, but you need that kind of open architecture or that framework that allows third parties to interact with you. It's no longer just about you providing a solution to solve this one problem. If you want to solve the issue around vaccine coverage, or if you want to solve the challenges around small agriculture and low yields and so forth, you need a ton of different actors from different environments involved. It's somewhere there needs to be that digital glue that holds it all together. And that's the bit that we've designed and are taking to market.
And I love hearing you say that, because it certainly is something that is, I suppose, of the moment right now when it comes to the concept of open collaboration, of leveraging the skills, the resources, the strengths of other stakeholders, other actors. And that is the basis of a community, of an ecosystem, right? And so that it sounds like that is probably the greatest sort of gift of what this interoperable system, this digital toolkit can provide. Something else I wanted to also ask is I suppose the next stage of what this kind of toolkit can do, because it seems to me, and certainly as we've spoken before, that the healthcare sector is really just one area of application for what this can do. It's almost as if you can kind of take the top off and put another color on, and then it can, start achieving results in a completely separate sector where there are other massive systemic types of issues that can be resolved. Where do you think those sort of next steps are for what this toolkit can do?
Yeah, so that's an important question. Thanks. And I sort of touched on it earlier, but we have the capability to solve an issue right now with ensuring that the vaccines that you have can get to the right people when they need them and where they need them. And that's a big plus, no question about that. But what you really want to do, given all the legacy challenges that exist in this complex environment with respect to healthcare in Africa, across many member states, and the chronic underinvestment and the lack of resources and so forth, we need to be able to position these digital tools to be able to start addressing many of those gaps. And you'll never do it in total for obvious reasons. You'll be able to solve one thing and then another thing. But the point is, in time, you can stitch them together and they can all run off the same common platform, as it were, with third parties and so forth, with legacy systems, interoperability and all the rest of it. And the point is that it needs to run off a shared services kind of framework or infrastructure. You can't, if you're going to deploy a solution, you can't just go put one server in here for that solution, another server in here for that solution, and different form factors and whatever. Ideally, you want everything to run off the same single instance, as it were. And if people are consuming mVacciNation or stock visibility component or anything else, whatever, they can draw on that on a per country basis. And being able to use that sort of platform economics thinking sharply reduces the bill that you have to pay. Like by orders of
Right.
magnitude.
Absolutely.
And that's super important, where people naturally and justifiably price sensitive around these things, because in the past people have sold all these fantastic solutions, but the total cost of ownership is so high that naturally they get scared, and that they don't want to come back and so forth. So that's a crucial thing, that platform sort of marketplace, platform shared services capability is that. Then the second is that the longer term view with respect to healthcare is around enabling recovery post pandemic and building towards resilience. We have a number of other elements within the toolbox. Just think of it like my child's bedroom. I'm actually in it, but there's a Lego box somewhere. He's got tons of little Lego pieces. And each one of those Lego pieces is one of the things that we've built for deployment in the primary healthcare sector. So if a government now wants to expand its capabilities or expand on the mVacciNation capability, they can add EPI. So the 8 or 9 vaccines that are part of what most countries provide to the children and so forth, we can accommodate that easily. In South Africa, that stock visibility component, I think, holds something like 1,000 different, essential medicines and other items like commodities and whatever. So in itself, that's scalable. But if a government now wants to look at something to do with supporting community health workers out in the field with assessing risk, and in other words, what you want to do is to keep people out of hospitals because it's just too expensive to support them there. We have tools to do that. If you want to now enable remote healthcare workers to start ordering pathology tests, so let's say you need a TB test, or you need a C19 antigen test, or you need a viral load test, we have a solution for that, et cetera, et cetera, et cetera. So you can start plugging all these things together with that same framework, and this is a sunk cost. So you land up just paying for that bit or that bit or that bit or whatever you want switched on or off.
The economics of it.
There you go.
Yeah. So it's, the application of it really has, the sky is its limit, I suppose, when it comes to maturing it in all these use cases, in all these different sectors that it could be used for. So with that in mind, I suppose just a last thought before we wrap up. What are you excited for, in terms of the coming years? Maybe it's the next 5 years, maybe even shorter term, but like, what about this kind of technology, maybe, and other types of technology like this allows you to sort of see a much more prosperous, sort of brighter future for the continent, for South Africa, for countries in Africa, where things just get better for those sort of last mile beneficiaries? Life is improved, even if it's just a little bit.
So I think there are a number of forces at play here, and the pandemic is just one of them. It's just, as I said earlier about the scrutiny, it's just pushed it right to the surface. Everyone can see it. Everyone understands where the gaps are, what needs to be done, and so forth. But there's a number of other forces, and one of those, for instance, is that funders, people that are injecting, like the World Bank and others, the EU, Washington, through various mechanisms and instruments, there's a huge influx of investment and stuff and resources. And that, with respect to mitigating their risk around the investment, ensuring that the beneficiaries actually do accrue the value, directly, there is no other tool that can be used except digital, effectively, to provide that visibility, and so forth. And so I think, and also if you look at the sort of history of the development of these kinds of tools, and particularly in mHealth, I think the GSMA, I'm not sure if they keep that database up to date. It's got something in the region of like 1,200, maybe 1,500 different mobile health interventions. And I can bet you that 2/3 of those are in Africa. And those have been very specific point solutions, often driven with donor money. And I'm not saying it's a bad thing. It's super important that innovation happens and is supported and stuff, and it should continue. But it needs to be done in a joined-up approach, because invariably what's happened is that you power these things, you send them out there and whatever, people use them for a bit, and then because of their funding cycles and because maybe they weren't clear about their business model, let alone their business case, it just drops off the horizon, and that kind of government's left holding the can, as it were. So I think there's a realization around a lot of the global public health players, global public health partnerships, and the people that fund those, organizations that fund those, is to start looking at other ways of coherently stitching this all together. So 2 examples. Digital Square, which is co-funded by Gates and by Aid, is doing some great work around that. Almost creating this sort of platform to enable beneficiary or countries and regions to be able to access tools that have almost been not quite validated, it's not the right way, but that at least there's a level of certainty around the quality of these things and how they're designed and maybe the business models and so forth. And similarly, the Global Fund and Gavi, about a year and a half, 2 years ago, did a similar thing with logistics management information systems, because there's so many requests by beneficiary countries, that appreciate the value that digital can bring, but they're not sure. There's so many different things that they can go buy. Which is the one that they should do? So the 2 of those organizations got together and did some good work in developing, this view and then almost as a recommendation around a set of pre-validated things. And so I think for me, those forces, and there just seems to be a cultural change towards acceptance of what we do, specifically around from a commercial perspective. And that's long been a challenge in this market. There's an expectation that it must be open source and it must be free. Well, the latter is impossible. There's no way you can provide a service at scale for free. I mean, someone needs to pay a number of people to be able to support this and maintain it. And I think people are understanding this more and more. But I think as these big actors get behind this, and with COVID as well, that convergence of all these things, I think bodes well for organizations like ourselves that are active in this space. But it's still, a challenging conversation that can take a long time and so forth. But that's what we do. I mean, it's, we're good at that. It's a multi-stakeholder, multi-funded environment. And we're a bunch of engineers except me, and we love complexity, and we're super good at it.
Well, you're the doctor. You've got to keep everyone on the straight and narrow.
Funny. Very funny.
Peter, it's been really, really good to talk to you. Amazing to learn more about how the mVacciNation digital toolkit is made up, is being rolled out, and how it's ultimately helping beneficiaries on the ground. And with all of these very important rollouts that need to happen in Africa, hopefully all over the world as well at some point. But we'll keep our eyes peeled on the big picture. Thanks again for your time.
A pleasure. Thank you. Thanks for having me.
Cool.
Thank you.
Thanks for listening to the Digital Lever. It's been great to have Peter Breitenbach, the head of product and strategy at Mezzanine. Make sure you follow the podcast on Apple and Spotify. You'll also see some clips on YouTube. We'll see you around next time. Thanks.